There are those times, maybe in practice, maybe just generally, where you come across symptoms or behaviors that just feel a bit well off. And figuring them out is really, really tricky. Makes you wonder what's actually going on underneath.
It really does. And having a solid framework for understanding those complex situations is just so important, especially if you're trying to pull information together for, say, revision.
Right.
We've got this set of revision notes here today, probably aimed at something like the MSRA, I'd guess. And our job really is to take this material and turn it into a focused, high-yield deep dive. We're zooming in on one condition that's often misunderstood: malingering.
Malingering, okay.
We're basically going to unpack all the crucial bits from these notes, help you make it stick.
Okay, let's dig in then. First things first, what exactly are we talking about when we say malingering? What's the sort of core definition these notes give us?
Okay, so at its heart, malingering, according to the source material, is the intentional feigning or exaggeration of symptoms, physical or psychological ones.
Intentional. That's the key word there, isn't it?
Absolutely. The notes really, really hammer that home. It's a conscious, deliberate deception. That makes it fundamentally different from a genuine illness or injury.
Or even other things where maybe the motivation isn't so clear.
Exactly, like, say, factitious disorder, where the motivation might be more internal, like assuming the sick role. Here, the notes clearly state the driver is secondary gain.
Secondary gain. Okay, what kind of external motivators are we thinking about? What do the notes list?
Well, the notes give a few common examples, things like looking for financial compensation, maybe trying to avoid obligations like work or military service, perhaps, or trying to obtain specific things like drugs. It's always driven by achieving some kind of external goal.
Right. And where does this tend to crop up? Which settings?
The notes specifically mention medical settings, obviously, but also legal or occupational environments. Basically, places where there's potentially something external to be gained or avoided.
Makes sense. Contexts where those incentives exist. Okay, so why? Why do people do this? What are the underlying reasons, the etiology, according to these notes?
Yeah, the why is interesting. The notes stress it's usually multifactorial. It's not just one thing, and it varies a lot from person to person.
But are there common themes?
Oh, yeah, definitely recurring themes. The big one, tying right back to the definition, is seeking direct personal or financial gain. That seems primary.
Okay.
Then there's the avoidance angle, getting out of responsibilities, difficult situations, that kind of thing.
Right.
The notes also mention it being used sometimes as a legal defense strategy, and in some cases it links to substance abuse, maybe trying to get access to substances.
And what about the person's psychology? Or social factors? Do they play a part?
Yes, definitely. The material points to psychosocial factors, too. Things like a history of being deceptive or manipulative, or maybe having antisocial personality traits. And sometimes just being under huge external pressure can contribute.
Right, so a mix of external goals and maybe some internal predispositions or pressures. Okay, building on that, why then? Are there specific things that make someone more likely to malinger? Risk factors we should really flag for revision.
Yes, this is a really key section in the notes, listing several important risk factors. For revision, maybe thinking about them in groups helps.
Oh, so?
Well, first, you could think about their sort of history and personal traits. A past history of malingering, that's a big predictor, according to the notes.
That's just reason.
Also, having antisocial traits is mentioned as strongly associated. The notes also bring up personality disorders and other psychopathology as potential associations. But it's crucial to remember malingering itself isn't a formal diagnosis. These are just factors often seen alongside it.
Okay, so past behavior, underlying traits. What's another group?
Maybe think about their current circumstances and how they interact with relevant systems. So things like financial stress, that's a major one. Lack of social support is also mentioned. And if someone's already caught up in legal disputes, or interestingly, if they know the healthcare or legal system really well, they might, see opportunities or ways to manipulate it.
Ah, familiarity with the system. Okay.
Anything else?
And the last one, linking back to motivation again, is substance abuse. That's listed as a clear risk factor, probably tied to wanting to obtain drugs.
Got it. So history and traits, circumstances and system knowledge, and substance abuse. That grouping does make it easier to hold on to. Now, completely changing tack, biologically. Is anything specific happening in the body Is there a pathophysiology described in these notes for malingering?
Right. This is a point the notes are super clear on. No,
Just me.
pretty much. There's no specific pathophysiological process underlying malingering.
No.
It's not like a disease causing the symptoms you see.
Okay, so it really reinforces that conscious, deliberate element.
Exactly. It's purely a conscious act of faking or exaggerating symptoms. The mechanism, if you want to call it that, is all psychological, social, external motivation, not biology.
Which also means the range of symptoms someone might present is, well, potentially huge. It really just depends on what outcome they're aiming for.
Which definitely highlights the challenge, doesn't it? If there's no biological marker, how on earth do clinicians or anyone else involved tell the difference? How do they approach the differential diagnosis?
That's the million-dollar question, isn't it? Differential diagnosis. Basically figuring out what's really going on. When malingering's on the table, the notes say the absolute key is a really rigorous, comprehensive evaluation.
Right. Can't just assume.
Absolutely not. You have to distinguish it carefully from genuine medical or psychiatric conditions.
So what does that comprehensive evaluation actually involve?
It means taking a really thorough history and paying close attention, looking for gaps or contradictions, doing physical exams naturally, using various tests and assessments.
Okay.
The notes specifically highlight looking for red flags during this process, things like inconsistencies in the person's story.
Yeah.
Discrepancies between what they say they're experiencing and what objective tests or observations show. And of course, looking for those clear indicators of secondary gain being the main driver.
So looking for patterns that don't quite add up.
Exactly. And the notes also really stress the need for a multidisciplinary approach here. It's not just one person's job.
Yeah.
Getting input from different angles, healthcare providers, maybe psychologists, legal experts, if relevant, that's vital. Everyone brings a different perspective.
That makes a lot of sense. Pooling expertise.
Yeah.
What about how common this is, especially in the UK context, which the notes seem geared towards?
Yeah.
What's the epidemiology look like?
Well, epidemiology is notoriously tricky for malingering. Why? Because it's inherently deceptive. People are actively trying to hide it.
Right. Hard to count something people are trying to conceal.
Precisely. So the notes acknowledge that challenge. They say prevalence rates vary hugely. Really depends on the specific context, the population you're looking at.
Okay. But are there settings where it's seen more often?
Yes. It's most commonly reported and probably encountered in those settings where secondary gain is a plausible factor. So legal contexts like personal injury claims, compensation claims, employment situations, think fitness for work assessments, that kind of thing.
Okay. And any particular medical specialties that deal with this more?
The notes mention forensic psychiatry and occupational medicine as specialties where assessing for malingering is relatively common.
Got it. So we know what it is, the why, the risks, the settings, but what does it actually look like clinically? If you were assessing someone, what might you see or hear that raises a red flag?
Well, because the symptoms are essentially chosen by the individual, the clinical presentation can be incredibly varied. It could be anything.
Right.
People might intentionally make up symptoms from scratch, or they might exaggerate genuine minor symptoms, or they might present symptoms in a way that's just inconsistent over time.
Any common examples the notes give?
Yeah, they list things like pain, which is obviously subjective and hard to disprove weakness, cognitive problems like memory loss, or various psychiatric symptoms like depression or PTSD.
Okay. And beyond the symptoms themselves, are there specific behaviors during an evaluation that might be giveaways?
Yes, and this is really useful stuff for revision, these behavioral indicators.
Right.
The notes point out several things to watch for. Think about how their overall presentation matches, or maybe doesn't match, how people with genuine illness usually behave.
Like what?
Okay, so you might get inconsistent information or even directly contradictory details given at different times or to different people.
Right.
Sometimes you might encounter an uncooperative attitude during the examination itself. That can be a flag.
Okay.
And this one's interesting. Sometimes there's a noticeable lack of concern about their supposed symptoms. It feels a bit off. You know, if you were genuinely suffering, you'd likely show more distress.
That is counterintuitive, yeah.
Absolutely. Then, crucially, look for those discrepancies between the subjective report, what they say they feel, and objective findings from exams or tests. And finally, the symptoms they describe might just not fit. They might be totally incongruent with known medical or psychological conditions, with known pathophysiology. It doesn't make sense medically.
Grouping those might help remember them too. Maybe like inconsistencies in their story, difficult interaction, weird affect, and objective discrepancy, something like that.
That's a great way to think about it, yeah. Finding those patterns.
Okay, those behavioral clues are definitely insightful. So if malingering is suspected based on that kind of clinical picture, what are the next steps? How do you investigate it further?
The notes describe a pretty thorough investigation process. And again, it often involves that multidisciplinary team, doctors, psychologists, maybe legal experts, depending on the situation.
What specific tools or actions do they take?
Well, comprehensive medical assessments, obviously, and psychiatric ones, too. A really critical step is reviewing all the available past medical records. You're looking for patterns, past inconsistencies, that kind of thing.
Digging into the history.
Exactly. Psychological testing is often employed. There are specific tests designed to assess symptom validity or look for signs of non-credible reporting.
Okay.
Objective medical tests like imaging, blood tests, lab work are important too, but primarily to rule out any genuine underlying medical cause for the symptoms being reported.
Right, making sure you're not missing something real.
Precisely. And the notes also mention that in some specific contexts, maybe more forensic ones, surveillance or monitoring might occasionally be used.
No.
Less common in standard healthcare, though.
So it's quite a layered approach, trying to build a full picture and spot any inconsistencies. What's the main goal of all these investigations summed up?
The aims are really clear. Identify those inconsistencies we talked about. Find, if possible, concrete evidence of the malingering or the symptom exaggeration. Definitively rule out any genuine illness that could explain the symptoms. And generally gather robust, objective data to either support or refute the suspicion of malingering.
Makes sense. Okay, so let's say malingering is strongly suspected or even identified. How is it managed? What's the approach? Particularly thinking about the UK focus in these notes.
Management. Well, according to the notes, it really hinges on the specific context. Is it a workplace issue, a legal claim, a clinical setting? That dictates a lot. But the constant theme is that multidisciplinary approach.
Right, and what are the core actions professionals usually take?
The key actions involve careful evaluation, obviously, but also meticulous documentation of all the findings, especially highlighting any inconsistencies or discrepancies found.
Get it all down on paper.
Exactly, and clear, consistent communication between all the professionals involved is vital. Everyone needs to be on the same page.
What about the legal side?
If there are legal implications, like in a compensation case or a criminal defense, those consequences are handled through the relevant legal channels. That's sort of separate from the clinical management.
Okay.
The notes also add an important point. If there are genuine underlying psychiatric or psychological issues identified, maybe things related to those risk factors we discussed earlier, like personality traits or substance abuse, then those underlying issues should be addressed and treated appropriately.
Right, treat the person, not just the behavior.
Exactly. And there's also a mention of preventative strategies, like education campaigns for professionals to get better at spotting it and maybe deterring the behavior more broadly.
Okay. What about the outcome for the individual? What's the long-term outlook, the prognosis for someone found to be malingering?
The notes say the prognosis is pretty variable. It really depends on a few key things.
Such as?
Well, the individual's specific motivation. Why were they doing it? How strongly motivated are they? Also, how do they respond to the evaluation process and any interventions? And critically, what are the actual consequences they face if the deception is uncovered?
Does catching it early change things?
The material suggests it can, yes. Early detection, along with a proper, thorough evaluation and management approach, might help discourage them from continuing the behavior.
But it's not straightforward.
No, definitely not. The notes acknowledge it's complex, outcomes are hard to predict reliably, and things like the results of legal disputes, if there are any, can significantly affect the overall prognosis, too.
Right. Finally, then, thinking broader, are there negative consequences, complications that come from malingering? Not just for the individual, but for the systems involved, for other people.
Oh, absolutely. The notes list some pretty significant complications for the healthcare system, for instance. There's the huge burden of unnecessary medical investigations and treatment.
Wasted resources.
Exactly. All those scans, tests, appointments, they cost money and, more importantly, they divert limited resources away from patients with genuine needs. And perhaps just as damaging, it seriously erodes trust. Trust within the healthcare system, trust within the legal system. It makes it harder for everyone, including genuinely ill people, who might then face more skepticism.
That's a really important point.
Yeah.
And for the person themselves.
For the individual caught malingering, the consequences can be severe. Legally, they could face charges like perjury or fraud. They definitely lose credibility, which can impact them hugely in any future dealings with medical or legal systems.
I think socially.
Socially, yeah, it can destroy relationships, lead to job loss, and have major financial repercussions, especially if they were chasing compensation that they now won't get, and might even have to pay back costs. If we sort of connect all these threads, thinking about that drain on resources, the erosion of trust, which the notes really flag as major complications, it does raise a really challenging question, doesn't it? For healthcare, for legal systems,
Right.
how can these systems get better at protecting themselves against deliberate deception while making absolutely sure they don't become overly suspicious and fail to provide compassionate, effective care for people who are genuinely ill? It's such a difficult tightrope to walk.
That really does capture the dilemma, that balancing act. Wow. Okay, so we've taken these MSRA revision notes and really done a deep dive into malingering today. We've covered the definition, the intentionality, the secondary gain. We've looked at the why, the risk factors, what it might look like clinically, how it's investigated and managed, the variable prognosis, and those really significant complications.
Yeah, hopefully breaking down those key points from the source material like this, maybe thinking about how they link together, makes this pretty tricky topic feel a bit clearer, a bit more manageable for your revision.
I think it certainly does. Well, thank you so much for joining us for this deep dive into malingering. And for you listening, remember, you can find more resources to help with your revision over at pastmsarrow.com.
And also at freemsra.com.
Great stuff. Thanks again.